Good afternoon. I'd like to welcome everybody to this joint meeting of the Health and Adult Social Care. We're also joined by members of the Children's Scrutiny panel as well. Do we have any apologies?
We've received apologies from Councillor Habib Anzaman and Kim Taylor-Kwapti.
And if we can just have a round of introductions from the panel members present, please.
And Councillor Jane Ryler, Home Valley South.
Helen Clay, Voluntary Co-op T.
Alison Munro, Almondbury Ward.
I'm Steve Gardner, a local general dental practitioner in the NHS and advisor to the LDN.
Hello, I'm Jane Moore. I'm the West Yorkshire LDN Chair. I work for the ICB as part of the commissioning team, and I'm also a practising dentist.
Afternoon, I'm Alison Cons. I'm Programme Lead for West Yorkshire ICB Dental Team.
Tim Bamford, Demodale Councillor.
Itrat Ali, Chair of Children's Scrutiny.
Thank you. Item number 2 is the minutes of the previous meeting. I take it that everybody's received a copy of that. Are there any items from the minutes you wish to raise? Can I then move that they are a correct record?
You may, Chair.
Thank you. And if we could just pop our hands up and go to the vote. Thank you. Are there any declarations of interest? Admissions of the public is everything that we will be discussing on today's agenda will be done in public. Are there any deputations or petitions?
None received, Chair.
And no public questions?
None received, Chair.
If I can then move on to item number 7, is the update on the dental services. Thank you.
Okay, thank you for having us here today. I'm just going to give a brief report from the report that we sent in a couple of weeks ago. We are now in a new financial year, so there is some updates onto there that we will be discussing today. So, in April 2023, West Yorkshire ICB took on delegated responsibility from NHS England for the commissioning and contracting of all NHS dental services. West Yorkshire ICB have agreed to deliver the dental commissioning responsibilities via a shared hub arrangement, and that will be hosted by Humber and North Yorkshire ICB, which also covers South Yorkshire. 2 years on, this report sets out a current update on dental services in Kirklees, providing a focus on services and the local and national direction for the future of NHS dentistry. Now, whilst West Yorkshire ICB has a remit for commissioning dental services, local authorities have also statutory responsibilities for oral health improvement, including the commissioning of evidence-based oral health improvement programmes to meet the needs of the local population. Both nationally and locally across the NHS dentistry is a challenge with issues identified relating to the national contract itself, workforce gaps and procurement restrictions, making it difficult to secure new dental provision. It's important to note that dental contracting takes place within the national context, and challenges are well embedded, meaning that West Yorkshire ICB have many issues to overcome in its aim to improve dental services. Improving access remains our absolute priority for West Yorkshire ICB, and since resuming delegated responsibility for the commissioning and contracting of dental services in April 2023, West Yorkshire ICB have been working hard to improve dental services for those living in the area. We're building positive relationships with the profession and local dental practice to continue to improve services. In Kirklees, in 2024 and 25, the ICB so far have increased the number of staff within the dental team. They can work effectively to support dental provisions, to support secure and stabilise dental services. We've developed positive relationships with local dental committees, the LDCs, to seek their input for future developments. We've invested non-recurrent funding in various initiatives aimed at improving access and reducing waiting lists, including an increase in urgent access appointments, an increase in orthodontic appointments over West Yorkshire and in Kirklees. 5 practices in Kirklees have been delivering urgent care appointments and offering approximately 18,148 patient appointments throughout the year, additional to core contract. We have 1 practice in Kirklees offering orthodontic practice. We've got 1 practice delivering homeless sessions. We've got a practice delivering 2 sessions for asylum and refugees coming into the area. We have a practice delivering domiciliary at 3 sessions a week for the patients in Kirklees. And we've got 1 practice delivering child 0 to 17, focusing on child deprivation, and they do 2 sessions a week within the Kirklees area. And we're currently working on a safe discharge and cancer and bisphosphonate pathway for patients living in the area. In addition to the statements that I've just mentioned, improving dental access, the ICB have all committed to continue its approach to flexible commissioning, which enables dental practices to work differently and to prioritise access for the most vulnerable. Through offering community outreach sessions and dedicated clinical appointments, flexible commissioning practices are able to focus on both prevention and treatment and access. At the time of this report, there were 12 flexible commissioning practices in Kirklees. However, with the start of the new flexible commissioning, which we've just commissioned, there are now 21 practices signed up to deliver flexible commissioning services. These 21 practices will have a start date of the 1st of April and will be slowly embedding them in to the service, making sure that access and prevention is priority in the areas of high deprivation and need. It will also depend on the skill of the workforce, but also identifying need and prioritising that accordingly. In 24-25, as we go forward, the ICB have also invited practices to deliver up to 10% of additional activity beyond their usual contract terms. The incentive encourages practices to work above and beyond their contracted level, with the assurance that the ICB will pay for the increase in activity. 6 practices across Kirklees applied for this and was working towards the over-delivery, and now that has completed on the 31st of March this year. We'll be looking at the incentive and the outcomes of that within June, as practices have 2 months to put their outcomes in. And as we've moved forward, we're going to be going out with expressions of interest for practice to deliver an additional 10% of contract moving into 25-26 to improve access. Finally, the ICB have been working hard and planning to transform the delivery of community dental services, that commonly known as CDS, provide dental care for adults and children with additional needs and those from vulnerable groups whose needs cannot be met within the general dental practices. Local community partnerships, the IC, provide the community dental services CDS within the Kirklees area and has now become part of a collaboration with the 4 other CDS providers in West Yorkshire, along with the Leeds Paediatric Service at Clarendon, under a lead provider model. The fully staffed, consultant-led service will serve the population of Kirklees and surroundings areas within West Yorkshire. Given the current challenges and the need to prioritise urgent care when it is most needed, further work has taken place to review and access oral health needs of the Yorkshire and Humber population. This report provides an update on the headline information from the recent work, including details of hospital dental extractions in children aged 0 to 19, which is a predictor of decay in later life and help to support future planning of dental services. In the next months, our focus is setting up schemes for dental in special educational settings and concentration on the additional of urgent care appointments set up by the government. An oral needs assessment in Yorkshire and Humber was completed in May 2022, and the purpose of this work was to help understand the oral needs inequalities across Yorkshire and Humber and was evidence-based. This helps inform the principles that underpin strategy and work programme development and address inequalities to meet the needs of the population and demand. The latest data regarding dental activity delivery shows that the practice in West Yorkshire on average are delivering 86.2% of contracted activity compared to an England average of 83.3%. Although slightly higher than the England average, this is lower than we would have liked, and we're working hard with practices to improve access and delivery of dental appointments. And this we are hoping will come from the flexible commissioning that we've provided and working with practices to open access. Patients often think they are registered with a dental practice in the same way they are registered with a GP, however, this is not the case. GP practices contracts are based on patient lists. However, dental practices are contracted to deliver activity. Practice is obliged to deliver a course of treatment to an individual, not ongoing regular care. However, many practices do tend to see patients regularly. This we would like to move on. However, the ring fencing dental prevents us from moving on this. This means that many waiting lists for primary care dentists are managed at local practice level. There's no central waiting list for dental care and no data available to support the list. We track data on the proportion of adults who have seen an NHS dentist in the last 24 months and the proportion of children who have seen an NHS dentist in the last 12 months. For the whole ICB, the most recent data shows adult access about 43.3% and children at 59.7%. West Yorkshire is the best quintile for England across both of these rates, and recent trend is that these rates are increasing. Adult patients seen in the last 24 months and children seen in the last 12 months by an NHS dentist are our priority. The local initiatives described are all delivered by West Yorkshire IB in order to meet the needs of the population we serve. In addition, there's also a range of national initiatives that we are focused on, largely introduced by the previous government, which we took on board and we delivered, which was an enhanced rate to pay to see new patients, an increase to the minimum tariff for units of dental activity, and the Golden Hello scheme as part of the national guidance. West Yorkshire ICB approved 13 applications for the Golden Hello scheme, 2 of which were based in Kirklees. However, those practices have found it hard to recruit and not gone ahead yet as part of that. That was due to finish on the 31st of March this year. However, we've extended that another 6 months to try and entice new people to come and work in NHS dentistry and take advantage of the Golden Hello scheme. So since these national changes were introduced, the Labour government is now in place. They're continuing with the previous plans and have set out new priorities for us. The new initiative to provide 700,000 new urgent care slots nationally equates to 32,312 new appointments in West Yorkshire, which we are working hard to provide, but comes out of funding that we already have. The prevention schemes, such as supervised toothbrushing, are still ongoing, and we're prioritising children. And we would prefer, we're working hard for the full dental contract reform, which is in government plans. To support our plans for improving access to dental service, West Yorkshire ICB is also offering workforce initiatives and pilots aimed at recruiting and retaining dentists in the area. So Kirklees Council, along with other local authorities in West Yorkshire, have received funding from West Yorkshire IB to improve oral health locally, and this work's involved 2 separate but integral projects. Local community dental services and additional funds such as Fresh Futures, working in wider community development, volunteers and VCS workforce are all part of this plan. Overall, NHS dental services remain a complex and challenging area. However, West Yorkshire ICB, in partnership with local authority colleagues and dental providers, working to bring about improvements. A revised focus on improving access to dental treatment through an increase in appointments, combined with a focus on workforce initiatives, preventative programmes via local schools, we all hope will bring positive change. Data sent out in the appendix shows the impact of some of this work and access for children and adults across West Yorkshire. Thank you.
Thank you for that presentation. You've given figures of nearly a third of 5-year-olds in Kirklees having experienced tooth decay, which was from 2019. Given some of the interventions you've done, do you actually have any more up-to-date figures on this?
We hope that will be coming. As I've said, providers have up to 2 months to submit their year end from the 31st of March. So we won't actually know those figures until June of this year to see what those. We can tell definitely that an impact last year was made, but the investment from which was just around 14 million last year into NHS Dental from non-recurrent funding. So that's activity that's not been provided by the dentist practice comes back into area and we reinvest that money. So that data will be available about 2 months.
Thank you. It would be good if you could actually send that in to us so that we can share with the committee there. just over 60% of children within Kirklees have actually seen an NHS dentist. Are you able to actually break that down? Because my concern is how many of those children, was it just the routine regular checkup, or the child that's got toothache and gets an emergency thing? And is also looking at sort of the number of like dentist practice within sort of is within Huddersfield is sort of the HD postcode with compared to like Dewsbury Batley, and that there seems to be a disproportionate amount of sort of dental practices there. Are most of these do you also have figures that would show that the children from sort of South Kirklees and North Kirklees are actually attending the dentist regularly?
So when we work as a Yorkshire Humber wide, and we then break that down into our ICBs, of which obviously we're West Yorkshire. We then break that down into our 5 place bases, which Kirklees comes under one place base. So that data comes as a whole for Kirklees, Dewsbury, going into that area as well. So the breakdown of data is quite difficult to actually pertain to a certain area. However, we do have practices. The difficult with practices, we don't get extra funding to put extra resource into practice just to have new practices in different areas. So if there is a deficit of practices in with a particular area, so we could use Dewsbury, Murfield, that area for instance, we never get extra money just to put new services in. So even though we know there's deprivation and we know that there is a need there, we don't have the funds to put a new practice in place. We deal with we've got a ring-fenced amount of money that we deal with, and practices are where they are forever. If they sell, they sell. If there's an occasion where a practice hands back some UDAs, to make it viable as a practice, that we need at least 7,000-8,000 UDAs. And I'm sure as Steve and Jane, who have worked in dental practice, will allude to, that is like one full-time equivalent of a dentist. So to attract somebody, you would need that amount of UDAs. The difficult there is if they're a single-handed practice, they don't have the peer support, they don't have all the extras that you get from working in a multi-practice where you've got colleagues that you can bounce off, you can share ideas, you can have that support clinically to make good planning for a patient. So it's very difficult to have a new practice open single-handedly. In fact, I've not seen that at all for years. So we work in the boundaries that we've got of dental. So the ring-fenced money, the practices are all embedded with UDAs within that practice. They work to that amount. If UDAs are handed back, which are very far and few between, it would be a small amount. And with those UDAs, what we do is an expression of interest, and we go out and we look for practices within that area. So if it was Murfield, Dewsbury, we would always look to put those UDAs back into that area. We wouldn't put them in, say, Crossland Moor or somewhere else, because that's just moving activity away from that area. We wouldn't do that. We always try and concentrate on the areas to make sure that access is equitable as much as possible. But we know there is deficits there. We know that we would love to put more practices in areas of deprivation and work with children and etc., but we just don't have the funds to do that, unfortunately.
Thank you. Obviously, you've got planned activity. You're also allowing the 10% commissioning or various things. One of my concerns is children's dental health, because obviously, if you can get them with good teeth as a children, they will go into adulthood. And I know is from the area that I represent, I was getting 2 or 3 requests, can you help find me a dentist? And all I was doing was going onto the website and saying, go to this one. Or if I saw a sign on at my dentist that they were taking on NHS people, I was actually posting that on my Facebook social media. It is, like I said, that is my main sort of concern, that we have this disproportion of dental practices across North and South Kirklees. And obviously, I think it's probably reflected in the amount of decay rates. I know Councillor Firth was telling me about how they paid for a van to come a few years ago. Are there any further questions? is Councillor Firth.
Thank you, Chair. Just a couple of things. Forgive me if I missed it, about school dentistry. In the good old days, or a very long time ago, should I say, I can remember that we had school dentists, and everybody was sent there. That no longer happens, I believe.
So as a local authority, that would be their responsibility if they choose to do that. As a dental commissioning team, we don't go technically into schools. However, as I mentioned in the report, we have worked with flexible commissioning practice. We've had a small number, and that's doubled in Kirklees, which from the 1st of April. So there is new initiatives there that we're working with local authorities and through flexible commissioning so that schools can direct patients to those flexible commission practices so that children can be seen. Like us, children are a priority, and we've worked really hard in West Yorkshire to up the ante on the flexible commissioning practice for access. We've also commissioned, in Kirklees, one practice who deliver purely children access. So we've got access there, so we've got a practice we can refer into. We've developed a level 2 paediatric service across West Yorkshire. It was done as a pilot last year for children so they could have inhalation sedation if they needed that in a dental practice rather than going to hospital. So it was a much nicer environment and it was seen quicker, you know. So we've had 2 of those practices working really hard over the last 12 months, and we're looking to increase that by another 3 because we've trained more level 2 practitioners so they can come into the area. So there'll be 5 in total. I take on board what you're saying about areas because obviously you're all likely to be invested in your own areas. We have to look at it as a West Yorkshire wide and deal with what we've got in those areas. So there is an expectation that sometimes we'd have to ask patients to travel. We understand there's a cost of living crisis and everything like that. And unfortunately, we'd absolutely love to put more practices in and work with more, but the money we have is ring fenced. So unfortunately, we do the best we can to try and serve the full spectrum, of the population that we serve, but we understand it is an issue.
May I come back, Chair? Well, that's good to hear, and I would hope that in the future that could be expanded. Though I note there's a new government initiative about that prevention is better than cure, and we've done that, by the way, in our ward. One particular school at high level of deprivation, we bought some toothpaste for every child and a toothbrush for every child. And to be fair, parents should be doing a little bit more on that. But they had some instructions about how to use them. It was primary school. But I believe the government intends to do that for every primary school to show how to instruct children how to brush the teeth. And if they keep up that habit, maybe we won't need these specific services that we've been just discussing now. We'll always want dentistry, but it may not be. We'll get out the crisis that they're in now. Thank you, Chair.
Thank you. Councillor Ryler.
Thank you. Thank you for your report, which was very interesting. I'm looking at 5.2 in the report, where it talks about since these national changes were introduced, the Labour government is now in place, and the priorities to focus on. It talks about the dental contract and having a full dental contract reform. I would be interested in knowing a little bit about the present dental contract and what might be maybe a better for the public contract in the future.
I'll start saying what the Commission's currently doing, and then I'm sure Steve will be able to, and James will a lot more. Thank you. So from a contracted point of view, a practice is given a number of UDAs. That might be 15,000 UDAs, it might be 8,000 UDAs, depending on the size of the practice. And that's historical. So we don't give them that. This is from PCT days when I were a dental nurse years ago, and that's how it stayed, for, since think about 2006, since it came in, the contract. Forgive me if that date's wrong. But thank you. So that number stays with the practice, and then the practice's responsibility is to go out and attract nurses, therapists, dentists to that practice to deliver the services there. So we look at workforce, we look at what can be done with a therapist, what can we do with a dentist, and they build their business model around those UDAs. Now, a UDA can range from £28, which the Conservative government came in last year and said that was an original start for a UDA. When I started, it was much lower than that. But a UDA price can range from roughly £28 up to about £40. So there is disparities there in itself. So Steve could have a practice at one end of the street on £40, sorry Steve, to a UDA, and I could be at 28, but we're still expected to deliver exactly the same. There's no change there on UDAs. So it's a bit of a hamster wheel when a practice is on there delivering UDAs. When you attract somebody to a job, it's hard to deliver the same thing, as I'm sure you'll all appreciate. UDAs are a bit of a wheel that goes round and it's constant. The way we've commissioned things in the last couple of years with West Yorkshire ICB is that we've offered projects to be delivered. So we've got the homeless project, asylum, domiciliary, paediatric. We've offered the 110% to get them away from that model of UDAs and allow them to deliver services in a new, unique way. I think that's the way it. And from that, we've had really good outcomes. Patients have given really good feedback. They're really happy with how they do because it's more person-centred rather than a wheel that they're delivering all the time. And we've worked really hard to do that. We run them all as projects, and in West Yorkshire now we've got 3 of those services embedded into contracts, so they've got security as a practice to deliver in a different way for 3 years. You know, we go out and speak to them constantly. We have monthly check-ins to make sure they're fine. We make sure that patients are attending. If not, we work with our stakeholders, which are the charities, to say, why aren't people attending and what can we do to make it better? So, for instance, homeless charities, we found that it wasn't no good in the morning getting people there, but in an afternoon we were great. We got people there, and we wanted to use the funding that we had in a really positive way and make sure people are attending. We don't want to sit there and not use UDAs. That's the last thing that we want. I'll hand over to Steve and Jamie because I'm sure they've got various things on the contract as well.
So the profession have been pushing for contract reform since the new contract was introduced in 2006 because we recognise that units of dental activity, UDAs, are not a good way to deliver the service. Now, in West Yorkshire, Kirklees, we have been really innovative as a commissioning team to introduce all the initiatives that Alison's outlined to try and move the practices away from UDAs and to give them an alternative way of delivering services which focus on vulnerable groups and prevention and access. And we have launched an initiative on the 1st of April to increase these initiatives, to increase the number of practices able to deliver services that are not reliant on UDAs. And this is the flexible commissioning pilot that Alison has described so eloquently. So if we had waited for the national team to develop contract reform, we would be no further forward now than we were 20 years ago nearly. So we are continuing in Yorkshire and Humber as a vanguard and with great success. So we are well ahead of the national team in terms of development of services, and I don't think that contract reform is likely imminently, to be fair, but we will continue to develop our services locally for the benefit of patients.
Thank you. Do you have a further question?
Just a quick one. So the salaries of all of the staff in the different surgeries is dependent upon the number of UDAs. Or is that
Steve's starting to come in here, but no, it absolutely isn't. So the owner of the practice has to pay all the staff, irrespective of whatever contract and whatever number of UDAs or whatever price they get. Steve's dying to say.
I think I'd just start by explaining, forgive me if you all know what a UDA is and how it works, but UDAs is a unit of dental activity, and there's certain treatments that attract a certain amount. And as a dentist in a deprived area, we get 3 units of dental activity for a fill-in. But we still only get 3 UDAs if we do 12 fill-ins. So in an area of deprivation where the incidence of needing treatment, actually you provide a lot more treatment to get the same amount of UDAs. That's where the current contract doesn't work. But as Councillor Firth mentioned earlier, prevention is far better. I have been part of the Flexible Commission, and we've used that extra time that is given to us to do more preventative work. It is going to be far better for us as a practice if we're doing occasional fill-in, none at all, preferably. If we're doing 1 fill-in on a child, that's a heck of a lot better financially as well. But obviously it's far better for the child if we're only doing 1 fill-in rather than 5 or 6. The UDA system, we do have a target of how many UDAs we do in a year, and that also sets a limit on the earnings of the practice. So that is your earnings as far as the NHS can, which is why private earnings is additional to that. So private is a completely separate thing. I am NHS dentist, always have been, always will be. So the UDA system gives you a set amount of income for that year, no matter how much work you do. You can't do it. You can't go over. Sorry, that's actually wrong this year. They did allow us to go over the limit very slightly this year for the first time. But normally you have a set amount of UDAs for that practice, and that is it. You have to achieve it. If you go below it, they take money off you, quite rightly, and they do give a little bit of flexibility now. But that's your set amount. And from that, you have to pay all your staff, dentists, nurses, and everything. So that is that's your income for the practice. That's what you use then to pay all your nurses and everything. Hopefully that's helpful.
Thank you. Helen, did you want to come in?
Hi, thank you. One of my questions was about the flexible commissioning, and you've just given a lot more information there that were answers to my question about what actually is it, what does it achieve, by how much, by when. So, yeah, any information that you've actually got that on that would be really appreciated. Thank you. Couple of questions. One was about, a couple of years ago, we heard about children waiting for an extraction for up to 2 years, I think it was. And the difficulty in getting, I think, as I recall, the biggest issue was theatre time. Back then, when we had that conversation, I think one of the responses was, we've just taken over, we've just, we're working towards, working hard, etc. Has that improved? Is that not an issue anymore?
Well, as a dentist, yes, it was a nightmare. A lot of it was COVID related. It ended up with such a massive backlog. And as a caring dentist, which I hope I am, when you're seeing children coming in pain and you can't do anything without sedation and everything, refer them, and they kept waiting and waiting and waiting. It was an awful situation. Anecdotally, I think it's a lot better now. Alison will be able to give more information about that, but certainly whether that's a result of the Flexible Commission and we're getting less cases needed referral, and I'd hope that would be the case. I don't know, as it's only anecdotal from my point of view, and hopefully Alison can give you more information on that.
So just on that subject alone, I've actually been speaking to a consultant this morning about paediatric GA access. The GA access has diminished considerably since COVID. Just accessing the hospitals, having the paediatric consultants is an issue. We don't have them as much as we did before for whatever reason. They're just not in there. So part of us working in collaboration with the CDS collaboration and having access to theatre space, that has increased. It's not where we want it to be, I'm going to be honest, but it's getting there. having the level 2 paediatric consultant in surgery, that's helped because that's where all the paediatrics go that can be seen within a practice and not within in a hospital.
Sorry to interrupt. When you say that's helped or
Yes.
that's... Could you be a bit more specific? Because I don't know whether that's...
No, I can...
We had 100 children waiting and we now got 5 or 10 children.
I haven't got the figures on me today, but I can certainly share those with you through the flexible commissioning as well. But yeah, the numbers for the level 2 have definitely, and it's definitely dropped, but I'll get the figures for you.
Thank you. May I have one more?
Yep.
Well, it's kind of 2 questions in one. So you refer to increasing the number of staff in the dental team. I'd just be interested, what are their sort of specific aims and achievements since they've been recruited? And also, in the 2 years since inception, what would you say have been the biggest achievements? What's actually come to fruition versus effort and outcome, essentially? Thank you.
Okay. So before we went into the ICB 2 years ago, there was just myself working in dental for the whole of West Yorkshire. I was contracts manager there. I had no real support. We had no administrative support. There was Jane working alongside me as LDN chair. But as you can imagine, we had over 300 contracts to manage in you know, both secondary care, orthodontics, primary care, of which we had 250 practices alone, urgent care, IMOS. There's just a vast array, about a massive portfolio. So that was until we went into the ICB, because there was a ban on recruitment through, because obviously with the changes were happening coming into that. Across Yorkshire and Humber, there were 7 of us looking after the whole of Yorkshire and Humber in the dental team. It's very limited.
Sorry, I'm sorry to interrupt. I suppose specifically, since those improvements have been made, and obviously what in practical terms, in terms of results for patients or dental practices, has that meant since those things have happened?
So in the last 2 years, we've increased the team. So we've now got a contracts manager. I've moved up to programme lead, and we've got an administrative. In ways of helping that across the board, we are able to support practices much more. I think I've always had an open door, and we've made that really accessible to all the practices, and I'm sure Steve can give his perception of that. But that means we can work with practices to deliver, you know, their activity. So they have to achieve 96% of contract every year, you know, before they get money taken off them. We don't want them handing money back to us. We would love that to get there, and that has increased year on year. So we've been able to go to practice and say, what's your issues? So it might be staffing issues. What have you done about that? How can we work with you? Have you tried this agency? How have you worked with staff? And we've got somebody, you know, that might be retiring. How can we keep that practice open? You know, just things like that, that all works. We've attended we've got MCN discussions, so we go into managed clinical networks for paediatrics on IMOS, which is intermediate minor oral surgery, orthodontics. We have links into those so we can improve services for patients. We increase pathways for special care patients so that patients aren't sat on any waiting list, they're seen in right place. We've looked at where patients are going into CDS, for instance, but might be really, you know, suitable to be in level 1, but just practices might not have the right staff. What we found from doing these projects is that it's really important to have the right mentality delivering services. And we've all 3 of us here have got different services that we've all worked in over the years. So we've brought our expertise into that and said, is it appropriate for a practice? So for instance, we might have a practice taking on a service and they think, oh, it's great, I can do this. But actually in real life, when those practices come in with alcohol and drug issues and they're sat there in front of a dentist that actually can't manage that, or the nursing staff can't manage that, or don't have the right attributes, it's really difficult to manage and plan for their case notes and everything to do that, because of course if they turn up absolutely drunk, we're not going to be able to see them, and quite rightly that puts your clinicians in an awkward position. So it's being able to tell the patient that without causing ruptions and issues in the practice. I think we've done a lot of work around just being able to be more transparent, open up, you know, working with them and putting those projects and these other things in place so we can move things forward in dental and deliver it away from the UDA base. So, yes, we've had 2 more, but sure.
I think all the projects that Alison has talked about, Alison has found additional funding to give the practices so that they've had a real impact on the patients, on the service to the patients. So particularly the homeless, the children and young people, asylum seekers and refugees, domiciliary. Those projects have all relied on Alison finding extra money, which she has done, to invest in the practices to enable them to deliver those services. And going forward from the 1st of April, what the flexible commissioning does is it allows the practice, they don't get additional funding, but they are allowed, instead of delivering UDAs, to deliver a preventive service to increase access. Some of that access is via 111, some of it is direct urgent care access, and a very robust preventive programme. So the practices have to have an oral health champion. They have to deliver a preventive programme within the practice. And I think it will be developed into some outreach as well. So possibly into schools going forward. So we're just at the start of that, and that is in addition to the additional funds that Alison has put into the other practices in terms of the other programmes, if you can understand that. Does that answer your question?
It does, and it's really helpful, thank you. I wasn't getting that from the report, and it's sometimes the devil is in the detail, and to have that reflected is really helpful to know what's actually, what's changed, what's different. And yeah, sorry.
Could I just say that
Absolutely.
As a practitioner, I've noticed a massive difference over the last couple of years with the communication with Alison. It used to be the case that you'd ring up or contact and it might be weeks, even months before you get anything back. But there's now, it's proactive. We're getting more done. So certainly in my experience, our practice, the productivity is up. We see more patients, particularly the young ones, which is what we're after. So yeah, from my point of view, there's been a massive change certainly over the last couple of years.
That's really good to know, really reassuring, thank you.
Are there any other questions? Councillor Munro?
Thank you very much. It's good to hear about the flexible commissioning. I just wanted to ask a few questions about new patients. So how many new patients are you managing to treat as a result of the measures that you've taken?
So unfortunately we won't have that data yet because we're just at year end and we take like I said earlier, we've got 2 months for all that data to come in, so it'll be about June before we get those figures in, but I can certainly share those.
If you could share them, that would be really
Yeah.
helpful. Thank you very much. And my next question is, with regard to the non-recurrent funding, how long is that funding likely to last?
We never know, is the answer. Right. So the non-recurrent funding is from, like I mentioned earlier, the practices that have not delivered 96% of their contract. That money comes back because it's ring-fenced within dental, and then we're given a figure that we just try and anticipate how much it is on the data coming in. Now, we know that activity is getting higher because last year we had 14 million to spend. This year it's 12, around that. So we know that activity has gone up. We know that more patients are being seen because we have got less to spend. It's kind of a double-edged sword because with that, we've only got 12 million to spend. And it's what do we spend it on, and who do we So we get together as a commissioning team, we look at our high needs deprivation, we look at what we're delivering so far and try and make the areas and touch every part of the population we can, and that is really difficult. Like it's a double-edged sword. What do you prioritise? Children is massive. That is just, that they're the future. We need to invest in them because that's what dental. We 100% are behind that as a team. That's our priority. We've worked with our consultants to say how do we manage that. Also, the government obviously puts different angle on it because they're saying urgent care, so it's like, okay, we've got to manage that as well and our expectation on that. So it is a bit of a juggling of priorities.
Yeah, sorry, can I just come in on that? So I noticed in your report that you've got 5 practices in Kirklees dealing with between 18 and 148 patients for urgent appointments.
Yeah.
And then you've just mentioned children now, 0 to 17 sessions, 2 per week. Is there any way you could increase the number of sessions? How long is a session?
So a session is 3.5 hours.
Right. So it's an
and
afternoon or a morning,
yeah, they deliver 2 sessions. Does the child? These are additional commission services, but again, we only get funding for 1 year. So every year we're looking round for more money.
Right.
So when I mentioned earlier about UDAs handed back from part handback, so sorry Steve, I'm going to use you an example, but if Steve ever came back to us and said to us, I want to reduce, I'd like to not work on a Monday, we're going to hand back like 4,000 UDAs. To that, then we would go out with an EOI to those practices nearby and say, we've got these UDAs, can you deliver them? On some circumstances, practices are just saying they can't deliver them because they don't have the workforce. That this year has allowed us to embed some of the services that we've done as projects and pilots into what we call, contracts that got GDS contracts which don't have an end date. What we've done is we've done it for 3 years, and we've done it for 3 years initially for a couple of reasons. One, it gives the practice stability to recruit, because nobody wants a contract for a year. That as the world is now, they want to have some stability. It gives the practice the ability to plan and get involved with schools and other charities to get people in, because again, you do it for once in a year, you might see one person and you don't see them again, so it gives a little bit of stability in that. So we've done that for 3 years. So in Kirklees, for the next 3 years, we know that we've got the domiciliary pilot, we've got homeless, and we've got asylum dealt with for 3 years. After 3 years, we can evaluate that, and it might be different priorities at that time. But we've also got some non-recurrent funding, like I said, for the level 2, paediatrics, we're looking at GA access, we're working with the local authorities, and working with other places to try and develop more things for children. That's the priority for this year.
Sorry, so when your children are attending these, the children aged 0 to 17 are attending these sessions, what kind of treatment is it just like a filling, or is it more complex, or
Everything. Basically, come in, priority is prevention and education. But yeah, they get a full course of treatment. They are dentally fit, which is the term. By the time they leave, obviously it's not only one session, of course, but they are dentally fit after this. And then what we do, we then absorb them into our normal patient list, and they will come again in 6 months and get back onto normal. So when those children, 0 to 17 now, it used to be 0 to 4, but when those children are seen, being dentally fit, and then we get them back and keep them dentally fit. So from my point of view, it is working.
Yeah, so they're effectively new patients that you're taking on, and maintaining a programme with health.
At the moment, for us as a practice, that is fine. Potentially, you could see that taking all these on might eventually be because too busy. It's extremely busy anyway, but I think it might be quite a while. You're going to get a natural drop off at the other end as well. So yes, they come in, they have a full course of treatment, they are dentally fit when they leave, and then there is future, they come back in as patients. So hopefully we keep those on and we don't have the same problems again.
Great, that's really good to hear. Thank you very much. Thank you.
That is very, very good to hear. There is one question that I've actually got is around orthodontics. There's one practice within Kirklees. What is the average time for, say, somebody being referred from their dentist to getting an orthodontic appointment?
I can say it's approximately 2 years now for Kirklees patients to receive from the time that they're referred into that. It's something they're working on as a team because we would love to extend the orthodontic portfolio, but again, that's ring fenced, so there's nothing. I have to work within the boundaries of what they're giving us for orthodontics. If someone handed us double that, then thank you very much, I would run with that. Because again, it's children, we need to prioritise. We've got patients that have turned 18, but they will get seen, even because the referral's done. And James, your orthodontic MCN lead, aren't you, with commission? So it is something that we do take as seriously, but it is 2 years at the moment.
I asked that because it's good to actually know that, and you can sort of manage expectations. The second half of my question was whether or not you've actually answered is the children that are waiting that become adults, but they would still be seen as well. Thank you.
Yeah, just to say that that waiting time is pretty much the same across Yorkshire and Humber. Kirklees isn't any worse.
Councillor Firth?
Thank you, Chair. How long does it train? Does it take to train a dentist? How many will be on the course, if you know, because I don't? And how long will we see the result of that dentistry course? The graduate, is it 3 years, 4 years, 5 years?
Well,
5 years.
Dentistry is 6 years now, but Huddersfield one, as far as I'm aware, is not dentists. It's therapists and hygienists. And there's a limitation to how much treatment they can provide. There's certain treatments, extractions, for example, they cannot provide. That's where the training is coming in. I think it's 3 years, the training for therapists and hygienists.
But can I ask, because you're the professionals, will that have an impact on the oral hygiene or the oral health of the people of Kirklees or wherever they go?
I would hope so. Recruitment is an issue. Again, from a personal point of view, fortunately for us, we don't have an issue. We're doing all right, but I know throughout Yorkshire it is an issue. Dentists particularly don't want to work in the NHS because of the constraints, financial constraints that are held. As I said, I am 100% NHS, always have been, but that is part of the reason. They don't want to put the amount of hours that are necessary to do the level of UDAs. It is hard. It really is hard. Again, like yourself said earlier, I'm old school. I used to see patients for 48 hours a week. That is just not done nowadays. And I wish I could turn the clock back, but that's quite rightly people don't want to work that amount of time. Now, what the therapists and hygienists are doing, allowing lesser qualified personnel to provide some of the treatment, which realistically is more cost effective. So if we can get these people into the workforce within the NHS, yes, hopefully we can increase productivity, but in how it actually works, I don't know. It's the future, obviously. So
it's going to be some years before that workforce has,
Yes.
has an impact anyway. And because of the shortage of places, I believe, in dental schools, dental colleges, because of the close a few years ago now, so they're not, sounds awful, they're not churning out enough dentists, qualified dentists. So it's a case of supply and demand. And so there is still a national shortage of dentists and will be for the foreseeable future. Am I right?
Absolutely.
I don't think there's been a reduction in the number of graduates in the UK, but a lot of them, the newly qualified, are going to Australia particularly. Just because there may be some training of therapists in Huddersfield doesn't necessarily mean that they'll work in Huddersfield, though.
Thank you. Are there any further questions? We do have Councillor Ryland.
Thank you. I just wanted to just get some clarification about some of the data. So this is on page 26. And it shows a map of Kirklees, yeah, and postcodes, and then the number of providers. The number of providers there doesn't seem very many. Are these just the NHS providers? Yeah. So for example, HD9, there are 4.
Can I just come in there? When you say providers, it's like I am a provider, but then I have a number of performers. So I provide the number of UDAs, but I have a number of performers, i.e. other dentists, who provide that service. So when you get that HD2, you've got one provider. That could be a practice of 8 dentists. So a provider, it does not reflect the number of dentists under that figure. So in my practice, as the principal, I provide the number of UDAs, however many thousand it is, but the performers, the people who perform those UDAs, are the dentists that work for me effectively in the practice. And that includes the therapists and hygienists and things like that as well.
So could they be working in different buildings?
Usually in the same building.
Right.
But so one provider could actually be 6, 7 dentists.
Right. Thank you. It's complicated. Yeah.
Thank you. Councillor Firth?
I'm sorry to be a pain, Chair, but following that line, how many actually NHS dentists are? We've got the basic figures here, 11 down to 3 on this long list, but how many actually NHS dentists provide that service in Kirklees?
This comes again, we need dental reform, because this would give us, we use a system that is quite clunky in dental. I think everyone thinks we have a really nice IT. We don't. For medical, they have lovely system 1 and EMIS that gives us information at a button. Dental, we like the poor relations because we work off spreadsheets and we have the BSA that coordinate all this for us. So I'm hoping if we ever get to dental reform, then that would be something that we can... Thank you. Thank you. We'll be behind you 100%. But yeah, it'd be lovely to have something like medical that we know, and especially for like flexible commissioning, that would be brilliant. I think when you've worked in medical and dental, you know the systems are out there for medical, but we feel sometimes like the poor relations to medical. And even though it's not teeth that that our clinicians do, they actually do save lives at some points, and that's not blowing things out of proportion, when you open a mouth, it's, Jane and Steve, we had this conversation before we came in, there's lots of things that they're checking, in there. We don't have a list of full how many dentists we've got. I could probably get somebody to have a look at that and see from just a Kirklees point. To be honest, I'd be interested, now that you said that, to know. But it's a really difficult one. When we have the contract, the practice put their performers onto there, but then they move around as well, and they may sometimes work at different practices. So they might be working at one day for Jane and one day for Steve, for instance, just as an example. So it's really difficult. The best way is going probably on the GDS, so you could have a look on the website. I was LDC.
The recent workforce.
Workforce data. Yes.
This is a new thing that came in last year. We have to now fill in data of how many staff we have working under the NHS and the proportion of time. So that information will hopefully be coming through.
You can go.
Can I just finish up, Chair, by saying that I do, and I'm sure colleagues do, appreciate everything you do. And you're certainly not the Cinderella outfit of the NHS. You're very much appreciated.
Thank you.
Thank you. That's much appreciated.
Thank you. We do have a representative from Health Watch if they had any comments. Okay, thank you. Can I actually just thank the panel for actually coming and giving a very comprehensive report and actually explaining, going through and answering all of our questions, and we also look forward to receiving the additional data, and thank you for everything that you actually do.
Thank you. Thanks very much.
Thank you. We'll just adjourn the meeting for 5 minutes whilst we have a swap around of seating, etc. for the next part. I'd just like to welcome everybody back, and we'll move on to item number 8, which is a verbal update on Kirklees Council's QCC inspection.
Thank you, Chair. So we're here to update you on our impending CQC inspection. I think we were here a few months ago when we got the actual call and we were preparing for the on-site visit, and then my fault, I updated Councillor Lawson saying we haven't got the date yet. Well, actually, we have now. So CQC will be on site week commencing the 26th of May. So another bank holiday period for my team. So happy us. So Lex is just going to take you through a couple of slides just to give you an update on where we're at, what we've done in terms of preparation for members, for our staff teams, and a bit of an overview of the timeline for when CQC will be on site, and some preparatory work that we're doing in preparation for that, because it's only, I think it's 5 weeks away, so all hands on deck. But Lex is going to go through a few things and then open for discussion really, and hope and invite questions from panel members. Thank you.
Thank you. Sorry, it's remiss of me. I should have asked you to introduce yourselves. My fault.
So sorry. So Michelle Cross, I'm the Exec Director for Adults and Health.
Hi, Kath Sims, Service Director for Adult Social Care. Hi, Alexia Gray, I'm Head of Quality Standards and Safeguarding Partnerships, so I've been the Head of Service that's been kind of leading on the planning and what's been needed for this inspection. So I just thought we have got some slides that we can put up, and we're happy to circulate these afterwards if you've not had them in advance, just as a reminder. So are we able to share those on the screen, or do you want me to... Yeah? No? Talk me through. I'll make a start, and then if they come through, that's fine. So we've sort of split the planning into 3 quite distinct phases. So part 1, we got the notification on the 9th of December to request to submit our self-assessment and the information return, which is known as the IR38, and that is literally 38 pieces of different information. It ended up being files of up to 120 things around data, around policy and procedures, around case studies. So it was a whole mix of things. And it was quite a quick turnaround. That had to be submitted by the 10th of January. So again, it was smack bang over the Christmas period, so it was quite difficult to get that done within that timeline, but we did, and that went in on the 10th of January. And then part 2, as Michelle said, Michelle got notification on the 17th of March, confirming that the on-site visit would be taking place on the 26th of May. So obviously the bank holiday is the Monday, so it could be the Monday, Tuesday, Wednesday, or it could be the Wednesday, Thursday, Friday. We don't have that detail yet. We were required by the 31st of March to submit a template of key individuals and team information, so that's gone in. And then they also require us to submit 50 case files, which again was submitted on the 31st of March. And then the CQC have picked at random 10 cases that they would like to focus on. So we've got to go back to them by next week with a lot more information and detail around those cases. One of the main factors being that they're really interested in speaking to the people who use services, families and carers. So we obviously need to make sure that we can get that consent from people before we put those through. We're currently in the process of quality assuring those because they need to be in by Tuesday. So we've got a team just making sure that the formatting and everything right's around the template. And then the next sort of big thing is the senior leadership team are asked to present an opening presentation of up to 3 hours on Teams. And that's booked in with the CQC on the 29th of April. We've obviously been in contact with other local authorities that have been inspected to glean their insights because we're not given any... They suggested a few things that they want us to cover in the presentation, but they are long. It's a long slide deck. They want to know the format will be that the Chief Exec opens. The Director of Public Health has a lot of input around demographics and sort of EDI data and things like that. Then it moves over to Michelle. We've got a big section from our principal social worker and principal occupational therapist because they're really interested in practice, so that is a whole chunk of it. And then we move to service directors to talk about their portfolios. And in amongst that, we've got partners that are doing videos to talk about sort of system wide connections and the work that's going on at system level. So there's been a lot of work again around that, but that's been finalised. We're meeting tomorrow to kind of go through that and just draft the timings of it, because it's only, 2 weeks away now, so we've got to be absolutely ready for that. And then in terms of the case file audit, I just thought it'd be interesting to show you, if we could just move on to the next slide, please. So the categories that CQC have requested are the ones on the left-hand side. And obviously, the people that access our services have probably got multiple needs. And so therefore, you have to select a primary category. So somebody, for example, might be an older person, which would be category CTO1, but they might have also recently come out of hospital, or they might have mental health needs. So the categories are quite important because that determines the cases. And then the requirements that we've got to submit for the 10 cases are the initial reason for the contact with us, a summary of the person's needs, the date of the first contact, the most recent assessment or review. So again, that's important because we need to let those people that are involved in those cases aware that their reviews will be submitted as part of that. They're interested around any referrals that have been made to other services and any multi-agency or contextual information that's relevant. And then I've already mentioned about the people who use services, but also contact details for the lead professional and a brief evaluation highlighting good practice and potentially if there's been areas for improvement. So as I mentioned, that we're working on those at the moment, and they'll be submitted by Tuesday next week. So that's the deadline for that. So what have we done so far? So we've done a lot of briefings with teams and staff, and that's been on an ongoing basis for the last 12 to 18 months, really, to keep people, to keep it in people's minds. We've also had some specific sessions with some independent support. So we had Partners in Care and Health and ADAS do some sessions with managers and frontline staff, which we got really good feedback on because they've got the expertise in terms of hearing what other local authorities, what their teams have been asked up and down the country, so that we were able to trial how would our staff respond if they were asked a particular question around that. Would they be aware of that particular procedure? So it was really good to pull all that out, and the feedback from that was good, both from ADAS and from our own staff, so it was definitely positive. Obviously, we've kept the executive leadership team briefed. We've had multiple portfolio holder briefings, and as Michelle said, we've been at Scrutiny previously to provide context around when the framework first came in, but then also how we've been progressing as part of that. Partners have been briefed, and we've also done regular updates at various service user forums, such as the Carers Network and Co-Production Board. And we've had regular comms that have been going out in a variety of formats very frequently, such as targeted emails from Michelle, newsletters and wider messages that need to go out council-wide have gone across the intranet. And as I said, we're on with the opening presentation and the case file audit. I think in terms of part 3, because now we know when the date is, we can work towards that, because it's been difficult trying to, just to give you an example, we can do all the work in the world with teams, but until you know that date, they're not going to, we've got to keep refreshing them. So now we know that we can do some really kind of work to support people that are going to be put in front of inspectors potentially as part of focus groups. So service users, families and carers will be contacted directly by the CQC, but the lead professional involved in those cases will obviously support those people with those conversations. We expect to hear from the CQC imminently about who they want to speak to. I've just been advised this morning that Wakefield Council have recently been inspected, and they got notified of a draft timetable the week after the opening presentation. So we'll get that from the CQC, and I think the reason they leave it that late is because they want to take on board the information from the opening presentation, look at the case file audits, and that might direct them down a particular key line of inquiry. But we definitely know that they'll want to speak to the Chief Exec, Director of Public Health, Principal Social Worker, Chair of Scrutiny, Portfolio Holder, and the Independent Chair. But the frontline staff they've spoken to in other authorities have varied, and I think that goes back to the point about a key line of inquiry. So if there's something that's stood out for them, then they might want to focus particularly on mental health teams, or it could be that they want a broad mix, and that's evident that it's not been the same groups of people that they've spoken to nationally. I think the other thing as well is that The CQC inspectors all come from different backgrounds, so again, that can influence lines of inquiry. We've seen that elsewhere. They also want to speak to the performance lead and our business intelligence colleagues a week before the inspection. We did submit a lot of data in January that was linked to things like safeguarding, waiting lists for assessments, reviews, financial assessments. It was very, very detailed. From what we understand, they don't necessarily revisit that. They don't want, another set of that submitting, but they may want to pull out bits. So I'll be supporting the performance lead around that in case there are any specific questions that come up around service or practice. Like I said, once we've got a clear idea of the above, the timetable will be drafted based on what CQC have sent through. They will be physically based at Civic Centre 1, but they do accept that some things might need to be done on Teams, particularly if it's a service user, for example, that would struggle to meet face-to-face. And like I said, we'll be doing bespoke briefings with all those that are involved. And, as I've said already, we've done that, all along the journey, but it's time now to just make that, to sort of ramp it up. So I think once we've done the opening presentation, the key activity really through May will be the logistics around the actual on-site visit, and then the engagement that we'll need to do with partners and key individuals and elected members that they'll want to speak to. So I think that's probably it. Thank you.
Thank you. Just going back to the case files you had to present, and you had the different categories. Was it 10 from each of those categories, or it was just?
10. Sorry, yeah, it's 10 in total. So there's 50 cases that we pulled together, and then so you've got 50 down one side, and then across the top it's got the various categories that case relates to, and then they've randomly chosen 10 from that list.
Thank you. Councillor Munro?
And first viewing, unfortunately for us, majority of those are older people who are from a white British background, which actually doesn't showcase the diversity of Kirklees. So we are doing some work behind the scenes to try and rectify some of that. And just to say, a case in point, that happened to Bradford as well. And considering the diversity of Bradford, they're going to have to work hard to sort of make sure that when people are seeing it does showcase the diversity. They did do a lot of that in their opening presentation, as will we. It's just the nature of how it's set up, and I think we've said previously we don't think that the actual framework is as robust as it can be. So we're hoping once they've done every authority across the country that there is some review of the framework, because it doesn't actually work, and it doesn't actually lend itself to actually getting into the detail of what communities do and how it's done across the whole of Kirklees. They just go straight down one line of inquiry. So I think there's some learning that will come out of this particular framework. So we'll see what happens next year.
Do you want to come in?
What your main kind of worries are with the whole kind of process, really. Obviously, I mean, you've got to be trying to be prepared as much as you possibly can, but there must be some areas where it's more difficult than others, or how are you preparing?
Yeah, I mean, I think certainly for us, and we've had feedback from other authorities, they seem to be really focused on EDI. Quality, diversity, inclusion. I think we've got a good story to tell in Kirklees, but it seems that every key line of inquiry that has an element of that. So it's making sure that when people are seen, when members are seen, when key individuals are seen, that they weave that into the things that they say, because we do really well in Kirklees, but we know there are gaps. And I think the trick with any of these is not hiding anything that you think is an area of development, but really showcasing the good work. And I think where councils have done really well, they focused on things like no waiting lists, because we don't have them, so we're going to go big on that as well. Camden got the only outstanding council, and they went really big on we don't have any waiting lists for care. And it wasn't just that. I think they had a really good story to tell. So I think if anything, is a worry. That's probably an area that we're more concerned about. But we've got the likes of public health involved in that. Rachel and her team are supporting that, and I think part of Rachel's opening presentation will be a real focus on EDI and what we're doing locally. The place-based working that we've got in Kirklees really needs to be showcased in that, and the Inclusive Communities Framework, it's probably one, it's quite unique. A lot of authorities don't have that, so it's making sure that we weave all of that in. So I'm hoping, in terms of the presentation, that they don't go down that line of inquiry too much, but if they do, that we prepare everybody in that space.
And just to add as well, we moved to a new case management system in adult social care February last year. So a lot of the data that we had to send, we've moved from one system to a new system. So we were a little bit concerned about whether that had transferred over correctly. Luckily, we've now had a year on the new system. When we were first pulling it together, we had a bit of data off the old system and a bit of data off the new, but now we've got a full 12 months on the new system, so we're a bit happier with that now. But, you know, that was a little bit of an area of concern as well.
Helen? Just touching on what you've just said, actually, about through the process of preparation, have you sort of like discovered areas of really good work that you perhaps weren't aware of, or areas of weakness where you've not necessarily been as obvious in the past?
I think preparing for the IR30, sorry, I'm dominating this. Practicing for my interview. Yeah, I think when we went through all that data, when we were trying to make sure that we had enough data to send in, we found out lots and lots of things. There did lots of work behind the scenes to correct some of that. I think that's fair to say, isn't it? But what it's meant is improving practice, and we know. And after we sent the return in, we've got a development plan that sits behind it. So if we are pulled up on anything, actually, there's a story to say we recognise that when we sent our return in. Like anything, when you're getting under the detail of everything at our level, it's not till you start to dig that you realise where the areas of development are. But we've shared some of that data, and I think the frontline teams have been excellent in being really open. But I think what it did show us, and Kath and I have had this discussion today when we did the sessions with partners in care and health, the frontline workers are absolutely on board and absolutely get what their expectation is, which was a lovely surprise, I have to say, because sometimes you don't always know what you're saying is landing frontline, and it really, really was. And the feedback from partners were, you've got some fantastic shining stars in here, you must make sure that you put them in front of CQC, because you do have quite a lot of control over that, so you can handpick who you put in front of them. And that's not to say that you're hiding anything, but it's almost bringing out your best in class so that you can showcase what is good in Kirklees. So it's been interesting and hard work, hasn't it, Lex?
I think the other thing we're really pleased about is the partnership working we've got across Kirklees, and that's come out really strong through the self-assessment. That's come out strong through the work with partners in health and care. They've said, you know, other local authorities don't have such strong partnerships with their ICB, with their trusts. We've got obviously the mental health trust as well, so that's a real positive that we want to shine a light on when they come as well. That partnership working, we're proud of that.
And also, I think what you're saying as well is that in the preparation, in terms of there are things that you're going to take forward after the inspection, regardless of the inspection result, but that you'll take forward. So it's I'm sure it's been really hard work and really difficult, but there are other positives, aren't there?
I think as well, to add that, you know, the things that we're doing, we would want to be doing anyway, because the point is around how we deliver services. So we're not doing all this work because of CQC, we're doing it because we want to get better outcomes for people. And if we can evidence that, then that should be the driving force behind it, not because we're getting inspected.
Councillor Firth.
Thank you. Team, you've sat patiently and listened to us talking about dentistry in the presentation. Does that have any impact on adult social care? Shortages of dentists to people that you deal with?
I mean, inevitably it will have an impact on sort of the population of adults across social care. I think from a personal point of view, sort of being registered individual for all our residential care, we don't get dentistry in like we used to do. They used to come and do visits. They used to make sure that people were supported in their own homes, but now that, unfortunately, that's fallen by the wayside because there simply isn't the funding to do that. So I do think that's an emerging gap. Unless we take somebody to an appointment or a family member takes their loved one to an appointment, quite often people aren't seen. So I think that potentially has an issue. And it was interesting listening to sort of young people getting access to dentistry. We know that SEND is a massive issue. I suspect that that's a huge gap. They do have specialist provision. Locala of the contract. I think they manage the contract for seeing those individuals, but equally they are subject to savings and budget cuts. So it'd be interesting to see what the impact that has on that cohort of young people transitioning into adults. So yeah, it was interesting listening.
Yeah, thank you. I didn't want to pick holes in your presentation. I just thought maybe, just maybe, you should think about that.
Yeah.
So clearly you have.
Thank you.
Councillor Ryler.
Thank you. It sounds to me as if you've got everything under control and you're confident about going forward. I was going to ask you about your teams and how they feel, but again, it appears to me that you're confident and and you realise what the good work you already have as teams. So I hope
I'll go first, and then let's can be a bit more honest with you. I think we have recognised that because of the timing of the call, it came in December. The team have not stopped and will not stop until after the bank holiday in May, and I am acutely aware of that as the director, and I have said constantly people really need to take a long break throughout the summer just to give themselves a rest, because it is relentless, and I think Lex and her team have worked tirelessly and are very, very, proactive and want to do a perfect job. But what I've said to Lex is they will see what they need to see, and we need to be a bit kind to ourselves, because what I don't want is a perfect show where in actual fact they will see the gaps, but I want to make sure that those gaps are seen, but they know that we've got a plan. So there is a well-being piece in that, and I think that's why we wanted to use all the resources that are available across the region and through ADAS, through LGA, so that people are supported. And I think there's some really good support for elected members. So we are pulling in that support all the time, and that's really important. And certainly from a director point of view, we are now, I think, most West Yorkshire councils have got the call, apart from North Yorks. So everybody is supporting one another. But you're right, we need to make sure that there is that well-being, that pastoral care of staff who are actually constantly, churning out work. So yeah, I am acutely aware of that, but I'll let Lex say, no, I'm drowning.
No, I won't. No, I think in terms of our frontline staff and their sort of confidence around meeting with inspectors, it's really quite nice to see that they're really engaged. So even just with, for example, the case file audit, people have been contacting Michelle, they've been contacting me because they want to know whether their case has been chosen. And as Michelle said, the feedback that we've had externally for when people have engaged with staff, it's been overwhelmingly positive. And I'm hoping that when we get that timetable through, that we can really invest, because we won't have any more returns to do at that point. It will just be around the planning. So we can use that entire month to really work with staff and make sure that they're in the best place. And like Michelle said, it's not about creating a condition where we're telling them what to say, but we want them to feel supported and that it is a safe space, and they can, we don't want them to, it would look, I think, very wrong actually if they didn't mention areas that they were concerned about. So I think we do want to work with people, but it's in that supportive manner rather than trying to dictate what somebody says or doesn't say, because that wouldn't be a fair reflection of the inspection, I don't think.
I think the other thing is, I think teams are sort of positive about the opportunity to talk about what they're proud about and the work that they've done, which is really good. I met with managers yesterday and deputy managers, and they know that they do good work and their teams do good work, and it's an opportunity to really demonstrate that and to have a bit of self-reflection as well about actually we're doing really well and we're doing our best and we do the best for the people in Kirklees. So it gives people the opportunity to you know, have some pride in what they've been doing as well.
Helen?
Are there areas that you're worried about? I mean, you don't have to say what they are, but I mean, are there things that you've got big concerns about?
I think there are some areas that we're not as strong on. Absolutely. I think there are some gaps, particularly around some of our commissioning strategies, some of our commission services. There's work to do. We had plans to improve that anyway. So I think when we're doing sort of opening presentations, we will sort of we will tell them about that. But because we've got a really good plan that sits behind that, I'm pretty confident that won't trip us up, but there's always areas in the Helen. I mean, adult social care is huge. There's always areas that we could do better on. But I think on the whole, she says, touch wood, I think, well, we are aspiring, I know everybody's touching wood, but we're aspiring to get good, because I think Kirklees is a really good place to live, work, and I think there's some fantastic work that goes on in Kirklees, and we really want to showcase that, but be honest again about development areas. It's really hard, because the feedback that we've had across the region is, regardless of what you say and what your return and what your self-assessment says, some of the reports aren't reflecting that. So it's really difficult, and that's general feedback. Some councils have challenged CQC because of lack of insight when they've actually done the on-site visit. And I think my disappointment, if I can say this in public, is that the presentation, you're not scored on it, which I find a little bit disappointing because of the amount of work and effort that goes into that. So you could do it, I mean, not that we will, but you could put less time into the presentation, but we don't want to do that, and nobody would do that. You want to actually bring out your greatest hits, and really sort of, that's your opening gambit of, this is Kirklees and this is what we do really well. But that just feels wrong, because a lot of time and energy goes into doing that presentation. 3 hours is a long time, so you're talking 80 up to 100 slides, which takes officers' time and things like that. So there's things like that, I think I alluded to at the beginning. I'm hoping that the framework is fundamentally reviewed.
Sorry, I was just going to add as well, because I've realised that I'd missed it off the last slide, but just in terms of the process afterwards, when the on-site visit is concluded, then Michelle has a feedback meeting with a couple of members of the team the week after. I think it's the 9th of June or something like that, isn't it? But then from that point, there can be quite a lag before you get the actual report through. So obviously Michelle will indicatively know what we think the outcome will be, but there's a period then where the report will come back. Obviously it'll need to be checked for factual accuracy. As Michelle said, is it reflective of the time that they spent? So for all the sessions that we do with staff, or that when staff meet in CQC, there'll be a debrief session that follows that straight away, so that we're keeping up to speed with the types of things that they're asking, and potentially is it something else that they'd want to explore based on that conversation. So that's how it could be even, I mean, it could be, the back end of summer, if not even a little bit longer before we get the report. So, thank you.
Thank you. Is there any further questions? Councillor Bamford?
Yeah. Do you think this long harding would look has raised your game anyway? From looking through, examining what you do and how you do it. That's one thing. And then the other thing, will the care home closures have any bearing on this, you think?
Oh, my mic's still on. Yes, I think it has upped our game, because we've had to go into a lot of detail about what teams are doing and how they're performing. We've looked at case files, which has obviously shown areas of development for teams and for us, and that improvement in practice was already in train. So yeah, to comment on the care homes, it's quite a difficult one, that, and I am certainly not going to have that in the opening presentation, because it wouldn't be appropriate to do that, because obviously that's still in legal process. So that's as much as I can say about that, really. But I would hope that would not be mentioned, if I'm honest. Thank you.
I wish I'd never mentioned it now. No, thank you very much.
Are there any other further questions? All is, having been part of a CQC inspection through, obviously, through my work, what I think it's a question of being able to look at what you do, that you're digging through the surface and actually finding out that most of the time you actually do a pretty good job, and it does help boost up morale from there, and it does look at, well, what could we improve, because with anything, even if it's sort of 99%, there's always some improvement. And I would just say to the staff that, especially the frontline staff that are going to be interviewed, is to actually look at what you do well and what you feel you yourself could be made better. And that's all I would actually give the advice to them, and it's not as scary as it's probably been thought of.
No, and I think the frontline staff are quite excited. I think they're quite excited to showcase what they're doing, and you know, that's the feedback, because I think when we did the sessions with partners in health and care, I think it was a realisation of, oh, actually it is about me and it is about what I do. It's not about the big managers who are sat over here. It's about me and what I deliver, which is nice, isn't it, that you're able to tell that story. So no, thank you. That's really helpful advice, which we will take back. Thank you.
Thank you. There's no further questions? Just like to thank Michelle and the team for coming, giving us this update, and obviously the best of luck. Not that you'll need it. Thank you. And I'll just move on quickly to item number 9, which is the work programme. And we completed it, because this is actually the last meeting of the municipal year. We will have probably the beginning of July a work programming workshop. So I'd like to close the meeting if nobody's got any further questions. Okay, we'll close the meeting. Thank you.